Afternoon and welcome to everybody to this workshop about clinical management challenges in infants and young children with achondroplasia organized by the European Achondroplasia Forum. I'm Encarna Guillen-Navarro, working in University Hospital Virgen de la Risaca in Murcia, Spain, and I will be conduct this session. Whoops, okay. Our objectives today are, these are our sponsor, Biomarine, Ascendi Pharma, Cuidit Therapeutic, Pfizer and Sanofi, and we are grateful to them. Sorry, I have some problem. Okay, thank you. The objectives for this workshop will be the following: to identify the key clinical challenges and barriers to effective management of achondroplasia in infants and young children, to review the outcomes of importance in infants and young children from a clinician and family perspective, to assess the application of recommendation in clinical practice, and to identify gaps between recommendation and clinical practice, and also explore the reasons for discordance. I don't know why the control. Okay, here. For those objectives, we have the following agenda, and it's divided in two parts. The first one is consideration in infancy and early childhood, going through three presentation from diagnosis through childhood, a family perspective by Ines Alves, assessing outcomes in infant and young children, Ines Alves and myself, and clinical challenges in infancy and early childhood by Valerie Cormier-Der and Marco Sessa. Then we will have a break, and after that we will discuss recommendation versus reality, overcoming barrier to best practice. The recommendation versus reality will be done by Geert Mortier. The overcoming barrier to best practice will be a discussion among all of us, and I will moderate it. And follow this discussion, we will have Eki Hart Lodge speaking about how might therapeutic option impact the clinical management. And finally, we will close the workshop and we will do a summary about that. And then we will have some evaluation question. I already indicated the speaker for every presentation, but here we have all of them. Myself, Ines Alves from Portugal, Valerie Cormier-Der from France, Marco Sessa from Italy, Geert Mortier from Belgium, and Ihard Lasch from Germany. And these are our disclosure. And after that, I would like to introduce Ines Alves to speak about from diagnosis to childhood, a family perspective. Thank you, Ines.
Thank you very much, Encarna. I hope you can hear me well.
Yes.
Yeah, okay. So I'm very pleased to be here today to give an overview with lots of personal input, obviously, around diagnosis and the family challenges on early infants and childhood. And what is important to start talking about, it's really the diagnosis stage. And the diagnosis stage can be quite linked to a loss of a desired child, that every parent wishes to be healthy and as similar as possible as them, but healthy. And having a child with a rare diagnosis, no matter what diagnosis that may be, is very challenging. And one of the striking points of this challenge is that to overcome not only the unknown of the future of that child, the potential medical complication that the infant may face, but also regarding the physical difference. And I will tackle this throughout this brief presentation. So this loss of the imaginary and desired child can be associated as a grief. And although some graphs can point grief as a continuous, in fact, it can be like that. And we can be back and forth in the acceptance of our child who have a rare condition as achondroplasia. And once we parents have that understanding that it's a fact and nothing is going to change that, it's time to search for answers, to try to identify the priorities, the questions that need to be asked in the medical appointments. And it quickly becomes a need to understand what are those scientific and medical jargons. What does that mean? And it can be quite overwhelming at the beginning, especially for parents that do not have any clinical background. And I can imagine that the majority of parents are in that group. So what is really impressive on that is that many parents also learn and develop new skills on understanding those jargons, not all, but the need to know, it's essential. And when we are assessing this need to know, quickly, we also understand as parents that the knowledge and the understanding of having a child with achondroplasia lies beyond healthcare professionals, researchers, and pharma, but also, and the majority, on the individuals that have achondroplasia, the people that have, the parents that live with that child, the parents that see that child 24/7 and are facing continuous challenges. And growing up, it's really about overcoming daily challenges and quests. And while having a child with achondroplasia can be a very, very complex challenge in new parents that have an infant or a child with very young age, that challenge is change across life. Because fortunately, we can see in different perspectives how life evolves and how the needs of that infant and that child and teen and young adult changes, and how parents also change their perspectives. But socially and in a global term, there are many aspects that are evolving during that lifetime challenge. And those are mainly the ones that are related to the quality of life, which is a very, very broad concept. And as you can see, it entails physical, mental health, autonomy, social relationships, everything that is related to our life. It's really what it entails. And as parents, we have to consider first this environment, close environment that is the core family, the more enlarged family. If there are siblings or not, there can be quite stressful and more challenging situations for parents that already have other children while facing a diagnosis, even if the child deals as well and not facing medical complications, is because all that process of overcoming the diagnosis and accepting it and teaching the child to be respectful for herself and for others and really accept that condition. And one of the points I really wanted to present in this moment is a statement between having a disease or a condition. And more we are defining, we are advocacy groups defining a condition, because it's something that does not take someone to the hospital every single day. A patient is someone that has to needs care, needs medical care. And achondroplasia is a lifelong condition, something that we live with it. We see someone living with it for all throughout his or her life. And these images are just a way to explain that in some periods of life, infants and children with achondroplasia are definitely patients. In many, they don't. They are just children with their challenges, as many others. And again, this is something that parents evolve in understanding, but it's something that I really would like to stress, that most of the times your patients are not patients, are just people. And one of the challenges that I believe that many clinicians have, and many, of course, many families have, is this understanding on this acceptance of the condition. And it's just really a snapshot of how different can be the understanding of having a child with achondroplasia. If we have a family that is average age and a de novo mutation happened, it was totally unexpected. How to deal with that? Or if we have a parent that has achondroplasia, how common, how natural may that be to that family? Or even so, having a family that both parents have achondroplasia, how can they see difference in a child that looks alike? And definitely, this is not a recipe that fits all, neither a magic formula that having a child with achondroplasia has the same complexity, social, medical, physical complexity. So I created this very basic matrix just to show that depending on parents, depending on their social environment, their cultural environment, their understanding of the situation, their overcome of the diagnosis, they can have different moments in life and selections of these pillars that happened that are essential for parents with a child with achondroplasia. And one of the challenges that parents really face since the first day they understand that their child will have a physical difference much more impactful than other physical differences across other children, among other children, is one of the biggest challenges. Because we are aware that bullying exists, we are aware that people can be quite unfriendly if there is someone with a different hair color, or if has more kilos than others. It's really about that difference and acceptance of difference that is very challenging for new parents. And when discovering that achondroplasia has been pictured across centuries in many different ways, why in the Egyptian times people with achondroplasia was worshipped. In the 1500s, they were pictured as people that were existing to please others. And unfortunately, still in the 21st century, we can see people amusing others. And this continuation of this medieval life is something that disturbs profoundly parents, because it's very difficult to live in this century with attitudes and images and stigmas still related to that period. And this was a questionnaire that I did last year in a national project to children that were between 7 and 8, so elementary school. And it was a 1-year project. And the idea was to assess how children understand difference and how well they accept it. And in this questionnaire, it was taken in the beginning of the year, the school year, and another recent questionnaire was taken the end of year. And this was the first questionnaire. And you can see that 30+% of children didn't accept to play with others if they were physically different. And around that same percentage associates having physical difference with having good marks or not having good marks at school. So this is still a statement of a bad link between being physically different and having something related with less capacity, cognitive abilities. And again, this was last year, and it's striking to see how children still react not as positively as we expect. So it's really critical for the education and also essential for parents in society to try to deal with difference more effectively. And then we have a new world of opportunities and challenges also for clinicians, for parents, with new decisions on medical treatments that could, in fact, produce change, depending on the child, but also raise a lot of hopes. And it's important to have that assessment of hopes and understanding of the new clinical treatments and how changes in life can actually be assessed. And see that throughout the many years, but while we are here tackling parents, families with children below 5, this is really a golden moment. And above all, what do parents with children with achondroplasia want? First of all, is really a clear guidance after treatment. Clear guidance, not just a medical guidance on what is expected, but on social terms, on educational, on support, on social security, everything you can think about. And having that expert care, it's not accessible to all. You know, it's really difficult when we live in different countries, very far away from cities where good hospitals exist. And in those good hospitals may not exist anyone expert on achondroplasia. So the challenges and the wishes are here. And definitely parents want their kids to be as physical well as possible, not ticking the box on all the complications that may be expected and can be expected in children with achondroplasia. They can just miss that part. And that's one of the major hopes of parents with children and infants with achondroplasia. And that throughout their lives, they just happen to blend with the crowd, to be just children as others. Those are the goals. Thank you very much.
Thank you, Ines. Perfect time. And you have bring very important question for the later discussion. We will proceed with the next presentation about the outcomes in infants and young children. But before, we want to review what was the survey and the general information about that. So this survey was answered by 33 health care providers and 55 parents. Most parents were from Italy and Portugal, how you can see on the slide. And the healthcare provider, most of them were from Germany and Italy and also Portugal. We also can see that most healthcare provider responder were from a variety of specialties. And we can see here family doctors, medical and clinical geneticists, orthopedic surgeon, pediatric endocrinologist, and physiotherapists, and also genetic counselor. And as you can see, the orthopedic surgeon were a high percentage, about 25%, followed by medical or clinical geneticist. And also another important data is that most parents were of average stature. Most healthcare providers also were based in an academic institution and followed by a general hospital. As you can see, primary care was missing. And in this setting where the most of the children were managed, we are also academic institution, followed by general hospital, and followed by primary care. Most children or respondent or children managed by responders were less than or equal 5 years, or between 5 and 11 years old, of course, in the pediatric age. So here on the left, we can say from the healthcare providers that these are from the less than 5 years of age. And we have a very few patients in older than 8 years of age. And on the right, we can see that most of the children, for the parents who were responding to the survey, were between 5 and 11 years also. Now we are going to review all the answers and analyze them in comparison. And through Ines Alves, who is going to bring us all this data. And then we will discuss a little bit about all the results. So Ines, please.
Thank you, Encarna. So let's see if I have control the slides. Yeah. Still not able to. Okay, thank you so much. I was not doing properly. So first of all, I think it's important to thank all the parents and healthcare professionals that responded to this questionnaire. Of course, we would like very much to have much more responses from European countries and not European countries. I really was like to see how many different clinicians from different countries responded. It was really, really good to see that. Very limited number per country, but very, very broad representation. For parents, I'm really sorry not having parents from other countries, mainly from Portugal and Italy, but a big thank you to all the parents that took 5 minutes to respond to the questionnaire. And it was really important to see how in some points, parents' responses and clinicians were quite aligned. So in regards to the most relevant outcomes in infancy, and considering that either clinicians and parents were requested to select among all these possibilities, the 3 more relevant outcomes for them, you can see that obviously the compression of foramen magnum is their top selection, because in fact is a complication that can be quite overwhelming, quite challenging, and it's a life risk surgery. So it's something that parents struggle, and clinicians are obviously aware of that challenge. And then it's more obvious for parents that decided among health-related quality of life factors that are related to independent living and to adaptive measures as support, kindergarten, changes in the car seat, how to travel with a child with achondroplasia, that kind of adaptive measures that parents struggle in finding responses so often. And sleep disorder breathing is obviously was obviously one of the most selected options by parents, which is one of the complications that frequently children and infants with achondroplasia deal with, and not all times it's easy to overcome the challenges of finding the right mask, to have the infant accepting having a mask, dealing with wakening at the night. It's not an easy task, but definitely it's important one to make sure that the infant is the best possible. And then other options were selected, but the majority of them for parents are really these three ones. For clinicians, the decompression from magnum, and also sleep disorder breathing was one of the most selected, and spinothalocumbar kyphosis, because in some cases they can take on fixed kyphosis, which is a medical concern, obviously, and some parents also name that. Taking to the next one, can you pass to the next one, because I can't for some reason. And in that questionnaire, some healthcare professionals and parents did share some comments, and as you will see from healthcare professionals from ages under 2 and ages between 2 and 5, the childhood, they are very consistent regarding identifying and addressing medical complications. So trying to be as clear as possible, informative, which is extremely relevant, and is also the way our information is shared. Sometimes parents are not yet prepared to read as deeply on medical terminology, but definitely having the opportunity to spend more time with those parents to explain them well what are the concerns and what are the future steps regarding the life of that child, and to make sure that that understanding of parents is secure. For parents, there were quite a few comments, and Encarna and I did a selection on those, and they are related mostly with the complications. That first challenge on seeing that there are quite numerous complications that can happen throughout the life of an infant and a child with achondroplasia. But parents also mention the psychological support and the lack of that support, basically. And in the graph that was in the previous slide that I didn't mention, I'm sorry for that, there were quite a few parents that responded the psychological support. Obviously, for a child under 2, they do not need psychological support. The parents do. And hardly we have multidisciplinary teams that can provide that psychological support. And that is a critical need, and still is an ongoing need. I speak in my country, and it's very challenging to find a solution for that. But parents do struggle with the diagnosis, the acceptance of that, and the understanding that they actually need support. But I'm glad to see that some parents pointed that out. And beyond those points that are there, social isolation was also mentioned. And somehow to develop strength and energy to overcome challenge, or some other comments mentioned by parents. and the risk of having their children follow up in centers where surgical approaches may not be secured the best conducted as ideally, and the risk that they may take their infant on if the surgery is not um, well done. So that was also one of the comments. Can you go to the next slide, please? So regarding to childhood between the 2 and the 5 years old age, things are more aligned, and parents have multiple selections here, but 2 are more striking: independent in self-care and psychosocial. Again, most of the children between 2 and 5 don't have or are not expected to have a lot of psychosocial issues. Yet parents do. And I think this is a reflection of the needs of parents rather than children. Although some children with achondroplasia can have early questions in their lifetime on why do I look different from others? But from the families I know, they don't tend to mention that assessment so early in life. Again, psychosocial is strikingly important, and maybe a discussion for new workshops. Educational, parents also pointed out the educational aspects, mostly due to those adaptations and finding the right kindergarten for their children. If the teachers and the educational professionals are ready to deal with a child that has different needs from others, that with a 2-year-old children group, that child may not be walking, yet it has to be aligned with the learning process of other children. And that may be a struggle for some parents, and I think that is well noted there. Regarding medical issues, otitis media was quite selected as well. And again, independence factors and adaptive factors and the health related quality of life. For clinicians, independence and self-care. Children between 2 and 5, regular children, common children, usually still ask parents to go to the bathroom when they are finished. Yet we can expect that to be in a continuity, to have continuity for years in life in a child with achondroplasia. But it's something that starts to worry parents very soon, that independence that will be very needed in later ages, and how to start to develop strategies for that. And also clinicians selected functionality, which is really very relevant because motor skills, gross and fine, are really critical to have that independence. So they are interconnected. Can you go to the next slide, please? And as I said, clinicians were very consistent on informing and making sure that parents are aware about symptoms, the signs that they need to detect early in life to prevent any other bigger complications. And now, as I presented minutes ago, regarding the new possibilities of having increase of height velocity, gaining, conversations also go towards to that. Parents are very curious, very in need to assess choices, options, and what in fact can change in their children's life beyond height. Regarding parents, what they did comment was mainly about autonomy and the critical aspects on education, not having or having very difficult times in finding a kindergarten in which the professionals are ready and prepared, or at least willing to be ready and prepared to follow up and support a child that has not developed motor skills as others. Yet one of the lines that a parent posed presented in the questionnaire was very striking. And it's the middle one, is in most situations, my child was used as a guinea pig. And that reveals the fact that still parents and people in society see in some cases that maybe research is conducted not in a clear way, or that they were not informally as properly as clinicians constantly in the consistent way mentioned how important is to be informed and secure the decisions. And co-decision process may be easier for some parents, but for others are not. So in some cases, and maybe in Southern European countries, is more paternalistic treatment for between clinicians and parents, because it's not well secure that they will understand what are the decisions to be taken off. But in fact, was really relevant to present this sentence, because there is a statement on the need to reinforce the quality of communication and the information that is given to parents, to make sure that no parent feels that their child is just being used on behalf of research with no clear and transparent benefit. And other parents also mentioned another comment that is not here, was regarding mental health. Again, that link between having a physical difference that is more evident than others, linked with not having physical ability, not mental health, I'm sorry, mental abilities. So that was what the parent mentioned. And that's another link that we need to overcome, but in a society level. It's not just achondroplasia, but definitely we need to have a clear assessment and clear view that having a body that is not as the average does not entail any limitation on mental and cognitive abilities. And that's it. Encarna, now it's to you.
Thank you, Ines. Again, I think it's very nice to have some time for discussion, because this survey brings us a lot of information. We can realize that there are different perspectives from healthcare provider and parents. And we then have some questions and for your consideration, such as do healthcare providers and parents need to agree on what the most important outcomes are? Should there be an agreed list of priorities to avoid discrepancy in opinion between healthcare providers and parents? And also, how might this differ for children aged below 2 years and those aged between 2 and 5? What can be done to improve communication of priority between healthcare providers and parents? And how are outcomes being measured in clinical practice, at home? I think all these are very relevant questions. And of course, now we have almost 15 minutes for discussing them. And I ask you to raise your hands and give us your opinion. I don't see now. Professor Geert Mortier, please.
Yeah, someone has to start. So
Thank you very much.
yes, thank you, Encarna and Ines, for this nice overview. I will not answer all the questions, but I think what I would say, as a clinician, and this is, I think, an important message for all clinicians, and most clinicians do know, is that it is important when you meet the family, when you meet a patient, and this is not just true for achondroplasia, but also for other conditions, that certainly at the first visit and maybe thereafter, that you always ask them what is their expectations and what kind of outcomes are important for them. I think that's because I guess it will be difficult to come up with a list of important outcomes because that will be individual. I can imagine that for some parents, height and growth is very important, and for others, it's less important, and it's more they are more worried about complications like the foramen magnum stenosis. So I think it will differ from patient to patient, from family to family, and I think we always have to keep in our mind that when we see a family, that we have to be as individual as possible. So we all talk about personalized medicine. Well, it's also true in clinical activities. We need to know what is their expectation, what is important for them, so that we can help them to the best. That's my opinion.
I think this is a very good point, because it's important to know the expectation of the family in every situation. I think it's a nice help for all doctors. But one other thing before going to close, Monique, do you think that it could be a difference when parents are of average stature and parent with the same condition or not?
Yeah, sure. And even within this, I mean, if you would consider the two cohorts, I mean, individuals I mean, if parents have the condition themselves, even within them, there may be differences. So I mean, that's my experience.
Yes, we don't have enough sample here from the survey, but I think it's also a very good point to bring. Thank you, and please, Professor Monique.
Yeah, thank you. I 100% agree with Geert, but I think sometimes we as doctors medicalize the families, and the families need some time to think about what we tell them. We tell them about complications and something else, but they also need that they have a child with some whatever life expectancy of also 70, 80 years. So it's not like they have to decide in a short time about diagnostic and treatments. You have to give them some time to settle down, I would say, before you tell them about pharmaceutical treatment and about surgery and so on. So I think first the doctor has to look if there is some kind of danger, but then you really have to give them time that they can have their own view how to care for their own child, and not to medicalize, I would say. Mm-hmm.
Thank you, Klaus. I also think that maybe time to settle down, as you say, for knowing the diagnosis. For also, I will like to point the need of enough time during the consultation in the clinic to speak and to allow all the questions that the parents have about the future, because sometimes the health system is also difficult to manage for the time that we need to speak and leave all the doubts to appear. So thank you for your comments. And now, Melita Irvin, please.
Hi, Encarna, how are you?
Hi,
Nice to see you. I completely agree with Klaus. And in fact, I don't mention clinical trials of vosoritide to parents with a newly diagnosed baby or fetus with achondroplasia until they mention it to me, actually, unless it gets to a point where I think they might report back to other families and say, well, we spoke to Melita and she didn't mention anything about trials. So I kind of try to strike a balance between the two things. But what I was going to say is that I get the sense from Ines' survey, in the survey results that she gave us, that there is a discordance between what healthcare professionals are considering as concerning things to look out for and what parents are considering concerning things to look out for. So one example was healthcare professionals seem to worry more about communication milestones than parents do. I didn't see hydrocephalus anywhere on the list. I don't know what if those were the results of the things that people gave you, or whether you asked people. I can't remember from completing the survey, I'm sorry, but hydrocephalus didn't appear. And I think a few years ago, hydrocephalus would have been a top concern, and that's kind of dropped off the list. So my point is that I think there is a discrepancy between what parents know about achondroplasia and families know about achondroplasia and what healthcare professionals acknowledge that is important about achondroplasia. And so we can't really, we're not on the same page yet to be able to listen to each other to say what the concerns are, because I have to look out for things that you might not know about as parents, and look out and you care for your child in those respects, whereas you might be thinking about other things to do with achondroplasia as parents that I don't see as important, because I'm looking out for the kind of safety welfare. So we're not on the same page yet, is what I'm trying to say. And maybe that comes into play with what you just asked Klaus about or Geert, I think, about the average stature versus the achondroplasia families, what they think. And actually our experience is the achondroplasia families are much more laissez-faire about everything. I think they don't worry so much about what could go wrong, when in fact they are the very ones that know what could go wrong. So again, it's just speaking to that that discrepancy between what everybody knows. We are not on the same page yet.
So Melita, for you, it's very important not only communication but also information.
Yes.
Maybe to close the gap between healthcare providers and families, right?
Yes. If we're expecting families to make decisions and to express opinions, and we are expected as healthcare professionals to express opinions that take into consideration the family's considerations, then we must all be on the same page and have the same information and be at the same start point before we can expect that to truly be something meaningful.
Mm-hmm. Thank you, Melita. And some other opinion from family perspective. I mean, Marco, maybe Marco want to make some comment. I have another hand raised, Svin Friedwald, and then Marco. Yes.
Yes, thank you, and thank you for some very nice presentations. I think my comment is in line with what have been said already, but I think there is a kind of communication that needs to go both ways, I think, both between the medical doctors or the healthcare providers and the parents, because I think we as medical doctors need to explain and maybe inform the parents about why we do all the measurements, why they need to do repeated MRIs, why they do need to come in for sleep studies, why all these medical things are important. It's a kind of education of the parents. Many parents will have learn this by themselves, but many parents also needs to be told this and the importance of all this medical follow-up, especially the first years. And I think that's important to kind of get an understanding, and also to reduce kind of the unnecessary concerns about this condition. And on the other hand, I think the survey and also illustrated that it's important for the medical professionals to listen to the patients and to learn what they are concerned about. So we kind of talking, we are also, so at least we can try to get on the same page, because they might have some other questions and other issues that we do not recognize. So I think it's a two-way communication, and I think it's important, both of them, because we need to develop a kind of common understanding of what's the most important things to address.
Thank you very much. We have only 2 minutes, and then we have 2 hands raised. So first, please, Marco, and then Mohammed Moni.
Yes, good afternoon, and thank you for to be here. And my opinion is that we are here. We are all experts about achondroplasia, but there are a lot of area of healthcare system. There are a lot of your colleagues that still don't know anything about achondroplasia. So there are families that every time that they meet a physician, they have to restart to speak, to explain what is achondroplasia, what means, what are the effects, and they are in that case the expert, not the physician, not the doctor who is in front. And this is something that we have to repair, because actually this kind of appointment are very important to create a culture and knowledge. But the ways is still long, and in the most of cases, parents needs help from the system, and from not only because they found a lot of ignorance about achondroplasia, and they are alone in that case, in that situation. Thank you.
Thank you, Marco. And please, Mohammed Mani, very briefly, because we are out of time.
Okay, I'll be brief. Thank you so much for bringing these data. They are extremely important. And I was quite impressed by the fact that parents feel that nothing was available in the education system to assist patients, children with achondroplasia. And I think that one of these considerations that you put should an agreed list of priority to avoid discrepancy. So I wonder whether this was different by country, and to what extent the anxiety of the parents could be, it could depend on education and other things. So this is something that I would like to know as physician, because the great part of physicians who participated to the survey come from the academic centers. So there is dichotomy between science and emotional. So would like to know more about this.
Yes, it's very, very important point, that one. And I think it could be something that we can clarify later. And we write down about that. So thank you, Mohammed, for your comment. And now we are going to proceed to the next part, which is clinical challenges in infancy and early childhood, presented by Valerie Cormier-Der and Marco Cesar. Please.
Yes.
Thank you, Valerie.
Yes, thank you very much, Encarna, and it's a pleasure to be here and to present this session with Marco Cesar. Just to come back with a few slides to introduce the survey and the results of the survey. Primary goals of achondroplasia management is to enable anticipation, identification, and treatment of complications. It is also to provide education and support to encourage a healthy lifestyle, avoiding, for example, obesity, to encourage positive self-esteem and mental health, and to encourage autonomy and independence. So we all know that close monitoring during the first 2 years of life is critical because unexpected infant deaths occur in 2 to 5% of infants with achondroplasia, and because apparent life-threatening events within the first 1 year of life occur in around 4% of infants. It highlights how neurological and respiratory assessment are important, including sleep studies and assessment for weakness in the lips. It highlights also why complications such as foramen magnum stenosis should be assessed and treated in early infancy. And it highlights also how anticipatory guidance in the early years can mitigate against future complications like fixed thoracolumbar kyphosis, hearing impairment, or language delay. Improving aspects of daily living can also benefit well-being and quality of life. For example, musculoskeletal impairments can prohibit full physical functioning. Children may require assistance with self-care and mobility for longer than children of average stature. Adults' physical and mental well-being can be impacted by physical limitation. And therefore, patients should have access to adaptive measures to the home, toys, clothing, school, or work environment, and to enable driving. Patients should have access to support to ensure proper usage of adaptive measures, including physiotherapists, occupational therapists, and surgeons. And patients should have access to approved treatment options, including both medication and advance in other areas. Marco, this is your turn.
Yes, thank you, Valerie. Good afternoon again to everybody. I wish to share with you some points, some aspect about what is the quality of life that, from my point of view, from point of an association, experience of an association. And the premise is that the clinical challenges means speaking also about quality of life, and the life implies complexity, different point of view, span, so change, improvement. And okay, complexity means that each subject involved in achondroplasia community bringing through that deserve respect, attention, and listening. And for parents, as Ines said before, for parents, the sense of guilty towards their children and the dream that has to being rebuilt and imagined after what happened. And for people with achondroplasia, of course, now in this slide we speak about children and infants, but for people with achondroplasia, as something is already said, that is to be considered as person and not as patient only a patient. And how we can do it, this, we as an expert. And we can also, we have to listening, to considering considering people with achondroplasia as exactly as a person with an experience that could share with us. Next. And we said that the language is important to define who we are. Ines said about condition and disease. This is a topic that we speak since I don't know when. But if we speak a disease, we are patients. If we speak about condition, we are person. And from my experience as a president of a patients association, that for scientific community, parents, average society, etc., this question is not a key point. In most of the case, actually, in the last time, it became a key point, but not so often. Okay, no, the before one, okay, thank you. And about that change in problem, we know that parents, children, adults with achondroplasia, and also a physician and an expert growth. In the last 20 years, each subject involved in achondroplasia is grown in knowledge, in culture, in experience. And this is very important. And this is something that defines what we are. And probably one of the results of this growing is to be here all together now to speak about achondroplasia through experts from all the parts of the world. Thank you. No.
So we are going to begin with the result of the survey. And we have decided with Marco to present some of the questions that we have highlighted looking at the data to keep in mind. So for example, for HCP, what makes a complication clinically challenging? Do the clinical management challenge differ for children aged 2 years or between 2 and 5 years? For parents, what makes a complication of achondroplasia challenging for you? Parents report that few complications were completely resolved following intervention. What are the reasons for this? And how this can be addressed? And HCP reports that complications are managed well or satisfactorily in their center. How can we improve this? And we will further discuss all these points after the result of the survey. So we will begin first with the parents' answer. Marco, would you like to comment this slide?
Yes, sorry. About the slide, we can see as the slide from before for people of less than 2 years, that for the foramen magnum stenosis and sleep disorder are one of the most important problem about the quality of life. And what I can say, I can say that this is something that we can know now in the last 20 years, in the last 10 years probably, because before this information there weren't. And for example, in my infants, all this information was when you have a kid age, you don't think that was probably a problem of foramen magnum. You thought that it was something that quite normal as all other person, other children. So it's very important for people with achondroplasia to start to understand exactly what can make the difference in your quality of life, in your healthy aspect for the future, of course, for the future, because most of this aspect will be influence our future, especially when we will be over the 30 or 40 years, not only when you are young.
So we are now looking at the answer from the HCP.
Sorry?
I'm going to change the slide.
Yes.
But it doesn't work. Okay, so
we can see here that probably there is the same, more or less the same result from HCP and parents of the perception what are the most complication in infancy.
Apart from otitis media, which seems to be one of the major problems in infancy from the parent side and not for the HCP, yes, where thoracolumbar kyphosis seems to be quite important. So there are some discrepancy, not for foramen magnum stenosis of sleep disorder breathing, but for otitis media, and also for quality of life. While for HCP, thoracolumbar kyphosis and orthopedic complications seems to be prevalent. And so we can move on to the next slide. So in early childhood, there are really some discrepancy. Looking first at for HCP, the most prevalent challenge are sleep disorder breathing, but also still thoracolumbar kyphosis and genu-varum. So mainly sleep disorder, thoracolumbar kyphosis and genu-varum, while for parents, the most prevalent challenges are otitis media, quality of life, and sleep disorder breathing. So there are major discrepancies dealing with HCP and parent apart from sleep disorder breathing, with again otitis media being really prevalent for parents, as well as quality of life, and orthopedic surgeon and kyphosing being quite important for HCP. So we can move on the next slide. And maybe Marco, if you want to comment this one for complication.
Yes, this we can see that there are some complications that are completely resolved after the treatment, and this, as I said, is very important for our quality of life. And yes, of course, there are still some problem, maybe for the probably we actually don't know exactly what means HR quality of life. So in this case, we have still some not clear point of view, but in general, for example, for foramen magnum, that is one of the most important problem and sleep disorder, the perception is that we have found a solution. We in the most of the case we have found a solution.
So we will move on the HCP answer. So as you can see here, for HCP, they feel that complications are managed satisfactorily or well in their center, very often extremely well managed in pink, but very often also very well managed in purple, and of course, never very poorly and very rarely poorly. So HCP feels that complications are really well managed in their center, and it may be a little discrepancy with the parents, depending on the types of complication. So this leads to some of our comments. Next slide. And maybe Marco, would you like to begin with the parent side?
Yes, for the challenging complication in infancy for parents, pain, persistent ear infection, poor hearing, upper respiratory infection, fear, stress, daily worry, exhaustion, understanding how to help your child. Physiological aspect, question, acceptance and an understanding. And the next slow diagnosis, referral, health care burden, hospitalization, examination, intervention, physio, ignorance of the condition by health professional, post-operative care expected from parents, difficult to lies in everyday life, and lack of clarity on option of management, indication for how to support child, and complication to be aware of.
So for the HCP side, there are a few questions and comments dealing with surgery, difficulty of orthopedic surgery, the need for surgical management, challenging to have expert neurosurgeon, how to know when to enroll orthopedic surgeon. So a few questions around surgery. A question dealing with otitis media, meaning that it is basic symptom, but with high repercussion on quality of life, and this is quite important. Challenging to have good quality of polysomnography, and also difficult to provide help to parents and to adjust daily living and to have good communication with clinician and family. And finally, difficult to have advice in coordinated way and to provide timely support. So mainly some questions around surgery, around communication between families and HCP and coordination. And we can move on to the last slide. So resolution of complication, maybe Marco, you can begin.
Yes, for parents, a spinal stenosis was a problem later in life, age 16, and that requiring lumbar decompression surgery. Hesitant to undergo any procedure due to lack of a national or regional expertise. He wears acoustic system and it recovered completely his hearing. Or necessary surgery still not performed. We have been on the waiting list for more than 3 months. We can say that in the most of the cases, there is also a problem of healthcare system. Her problem remain with a frequent ear infection. The weight is the most difficult to control. Quality of life was improved, but limitation remain.
Thank you. So for the HCP part, clearly obesity is a real challenge because we don't have any specific advice to give expect the usual regarding diet and physical activity. Question of the expertise and the importance of having an orthopedic surgeon, expert in the field. So question of experience again, with still challenges in managing achondroplasia children owing to the lack of knowledge, and question dealing with development and quality of life. So I do think that we have finished to discuss the survey, and that now we can open the questions. So beginning, showing again some of questions for consideration. What makes a complication clinically challenging for HCP for parents, and how can we improve communication maybe and information? So thank you for your attention, and if you have any question, please feel free.
Thank you.
Thank you, Valerie. Thank you, Marco. We have like 5-6 minutes for discussion, and maybe to have some comment from all of you about this question that Valerie brought us.
So we are in the same lines that we have just discussed, question of communication and information. I do think that there is a question from Mohammed.
Yeah.
Comments?
Just a comment. I mean, I was looking at the data. Hi, Valerie. Thank you so much for presenting these data, and Marco. If I look to the weight, I mean, the comment is that the weight is the most difficult to control. While if you look how many people were worried about this, and only a small portion of parents who were worried. So there is misperception on how many are worried and to what extent they are saying that is difficult to control. So this is something that I can understand very well. And the spinal stenosis in the 5-2 and 5-year, why this is worrying for the parents? I mean, this is a late complication. So I would like just to invite to be careful about how interpreting these data. So this is my feeling by looking at which is extremely important. But my feeling is there is a big divide between what the SPC feels and the parents feel. And if we are talking about mainly academic centers, then somebody of the parents is saying that the ignorance of healthcare professional. So who will be the target? Are the academic centers ignorant and they are not aware of the complications? Or we need to extend the awareness to general practitioners and others? So I have just on these comments, Valerie. Thank you so much.
Thank you. I agree that there is a lot of question around expertise, because not all centers can be expert in achondroplasia. So this is a major challenge. Who is expert and how do you become an expert? And there is also a lot of question around quality of life and the importance of quality of life. Maybe Brigitte, Brigitte Forroux?
Yeah, thank you. I think this is very important. And I have a question on the multidisciplinary team, because you need to have subspecialists for the different multi-organ involvement of those patients. In other words, you need a pediatric orthopedist, but this surgeon needs to have a good knowledge on achondroplasia. The same for sleep studies. I'm a pediatric pulmonologist. I do sleep studies, but if I give a sleep study just to a pediatric sleep specialist who has no expertise in achondroplasia, the interpretation of the sleep study will not be correct. So I think the specialists need to have a double expertise on their domain, their subspecialty, but also on achondroplasia.
Yeah,
and that makes it very difficult.
So I fully agree, and so I don't think that everyone can be expert in achondroplasia. So the multidisciplinary team is crucial, and especially involved in achondroplasia. Melita.
Yes, thank you very much, Valerie. I wanted to support Mohammed's view about why spinal stenosis might be considered as a major issue in this young cohort. And again, I think that speaks to the fact that there are either achondroplasia established families that are presenting that as the concern, or people of who are of average stature that have a child with achondroplasia are talking to people with achondroplasia who will be adults, who will then express concerns about achondroplasia and the spinal stenosis complication. So again, I think there's a mismatch between information that people hold. And what I wanted to say a little earlier on in one of the presentations was about sleep disordered breathing, and it is my experience that that is the major consideration and major concern of parents of young children, infants with achondroplasia, because they can see it, they can hear it, they experience the sleep disordered breathing, whereas they can't look at their child and see foramen magnum stenosis or see some of the other complications that we might worry about as clinicians. So it's a very much a something something tangible that they can experience, and therefore react to, whether that's normal breathing or disordered breathing. So that's what I wanted to say on those 2 points. Thank you.
Yes, thank you very much. And if I remember correctly, we have to select the 3 most prevalent challenges for the survey monkey. It is a reason why maybe for weight it was not mentioned, because it was not one of the 3 most prevalent features for the survey monkey, but it is extremely difficult to manage as HTP. So maybe we need to remember how the survey was presented, yes, to understand the answer. Yeah. Any other comments or questions? Geert, yes.
Yeah, I also want to make a comment on the spinal stenosis. So I agree with Mohammed and Melita that it was a bit strange. But also, if you look at the answers from the healthcare providers, there were a few healthcare providers that felt that this was an attention point even in the very young infants. So that tells me that even they do not know what exactly is going on in this age group. So this also tells us that even within academic institutions, healthcare providers are not fully aware of what kind of complication at what age are important.
Yeah. And Sven?
I just wanted to comment on the discrepancy between the healthcare professionals and the parents about the satisfaction with the treatment and follow-up, because I think that might be an issue of expectations. You know that most of these institutions are academic institutions. They have probably seen several patients with achondroplasia before, and they might think that the treatment and follow-up is within the best according to guidelines and what we could expect, but maybe the parents had expected an even better outcome. They were hoping that actually we can fix things so that things could go away, but still some of these complications will be there. They will be there to some degree, and they may come back. So I think there could be some discrepancy between that, and it's not necessarily a contradiction. It can just be 2 different perspectives on the expected outcome.
Yes. So maybe Marco, would you like to say something to conclude the session? Maybe no.
No, maybe about I wish to answer to Melissa and Mohammed. Probably there is a in the parents, for maybe there is a for stenosis, there is a legacy of the past. So I remember that this was a problem when my kids was young, and then so it's remain for all of life, maybe.
Yeah.
Thank you. Thank you, Valerie. Thank you, Marco, for this nice presentation and discussion. Hello, everybody. We are going to start the second part of the workshop, and we are going to review the recommendation for management of achondroplasia versus reality with Geert Mortier. And thank you very much, Geert, and please proceed with the presentation.
Okay, do you hear me?
Yes.
Okay, good. So thank you. Indeed, we are now in a new session, recommendations versus reality. So, so actually, there are two questions that we have to discuss. Two questions that were given to the healthcare providers and the parents. So the first question was, are you aware of the recommendations? And on the first slide here, you do see the two papers. So you had the position statement paper on the first European consensus on principles of management for achondroplasia. So that was the first paper. And then the second one is the international consensus statement paper with Ravi as the first author. So we asked the healthcare providers and we asked the parents, are you aware of that? Remember from previous slides that when we are talking about the healthcare providers, that they were mainly in academic institutions, and also remember that, for example, 25% were orthopedic surgeons. And then the second question was to the healthcare providers, do you align with these recommendations? Did you adhere? Did you take into consideration in your daily practice within your institute these recommendations? So these are the two questions. So let's start with the first one. So this gives you the results of the parents. And as you can see, the majority is not at all aware. So this is the blue box. So the majority is not aware. There are a few, let's say 7 on top of the total that were aware and that actually read it. So this is the left box. And then the purple in the middle is, yes, I'm aware, but I did not read it. Some comments from the parents are also listed on the right side. We have translated consensus recommendations and shared it within our network. Someone said, well, it is useful to have these recommendations. And then someone else said, well, I'm totally unaware of any guiding principle for the management. So it shows you really the diversity in knowledge of the guidelines. So this was the responses, or these are the responses from the parents. And we see, in fact, the opposite. And that's something, of course, that we expect. So we do see the opposite when you ask the same question, are you aware of these recommendations to the healthcare providers? Then you see that, and then it's divided between, I didn't say for the parents, but you have the paper from the European Achondroplasia Forum, so from this forum, and then the paper, the international one. But the tendency is the same, and so most of them are aware and did read it. Some comments also from the healthcare providers. Well, I'm an ophthalmologist, so I'm not aware of that. And of course, if you're a co-author or if you're a contributing author, then of course you are supposed to know and to have read the paper, and that makes sense. So that was the first question. Then the second question, and these are busy slides, but I will take my time to go over it. The second question was only to the healthcare providers, and was asking, do you align, do you adhere, do you take into consideration the international consensus recommendation for managing achondroplasia, first in infants? So the first slide is on infants, and then the following slides will be for the children. So it's a busy slide, so I try to highlight the most important words in each recommendation that is listed in this table. And then on the right side, you see, well, the ones that completely aligned, the ones that somewhat aligned, and then the ones that did not at all align. So if you look at the ones that did not at all, so there were a few, 1 to 2 people who said, I'm not aligning with this. And then if you look for which recommendations, then there was one for multidisciplinary team. So the necessity to have it closely monitored in the first 2 years and to be followed by multidisciplinary team. The second one was about the fact that you have these developmental milestones that should take into consideration, and that you have these that these milestones and the screening tools are achondroplasia specific. And then another one was not aligning to the recommendation 31 at the bottom, hearing evaluation, which is recommended. And then 2 people at the very bottom, which is a bit surprising to me, did not adhere to the fact that these children should have their regular vaccinations. It's a bit puzzling to me why they did not align with that, because that seems to be the most easy one. So these are the recommendations where we got some scores of not at all. If you look at the completely, the column with the completely and the somewhat, you see, well, the majority is completely, and then about half of them or less than that is somewhat. Of course, we have to, within this, when we look at these data, there are of course different things that comes up. Why do they say that they do not align? What are the possible explanations? It could be that, well, they are not aware. That, of course, if they are not aware, they cannot align. A second possibility that I do see is that they feel, well, I'm aware, but I don't think it's important. A third possibility could be, I'm aware, it's important, but I don't have the expertise, or my hospital or my institute is not really supporting me in this. So these are kind of possible explanations for why people do not align. For example, if you look at, I can see that, for example, for the multidisciplinary team, you can imagine that this is maybe not so easy for everyone to align, because that involves the involvement of other people. But for example, for the milestones and the screening tools, then you would expect, if you're aware of these milestones, it's not a big problem to actually adhere to these milestones and to these screening tools. So that could explain a bit the discrepancy in these kind of recommendations, in the fact why they do align and why not. So this is for infancy. Then we have 2 slides on for the young children, so for the age group between 2 and 5 years. And then again, if we look at the column not at all, there were 3 that did for 3 recommendations that there was not alignment. The first one was for audiology, hearing assessments. The second one was for speech and language delay. So the recommendation to refer for speech and language therapy. And then the other one is recommendation 58, physiotherapists, sorry, and or occupational therapists should review children with achondroplasia. That was the recommendation. And the last one was for the fact that trips and falls are common in children when they start to walk, and parents should be encouraged to keep their children active. So the same kind of reflections that you can have that I did for the previous one, so I will not repeat that. And then again, you see that the majority is completely aligning, and then less people are somewhat aligning. If we go further to the second slide, then again, you see an additional 6 recommendations. And if you look at the column not at all, well, 5 did say that they are not aligning with the recommendation that the possibility of children with achondroplasia undergoing lymph lengthening procedures might be discussed. There I do see that maybe the expertise is lacking, or maybe the age is not appropriate. And you will see that in the comments on the next slide, that some of them said, well, we are not aligning with the recommendation because the age is not proper. They should be discussed later on. And then you can see the other data. I don't think it needs that much comments, but I give you the time to read it a bit. Okay, then we go to the next slide. So here we have listed some comments from the healthcare providers on this question about alignment. And I've tried to cluster them a bit. So the first ones are mainly mainly related to travel distances, the fact that these national referral centers are not everywhere, and that there are delays, that they are not referred. Then any shortcomings are usually the consequence of devolving to local services. So there you see some problems in the fact that these national reference centers are not easy accessible. They are on they have a distance, they are remote from the patient, and the other thing is that the local hospitals and local physicians maybe not always do refer to the national center. So this is one major comment. And then a few comments on sleep evaluation. Sleep lab evaluation depends on the personal experience of the center. Convincing other departments on need for early sleep studies, limited access to sleep studies. So this actually illustrates the things that I said before. And so the fact that they are not aligning is not because they are not aware. It's not because they don't feel it's important, but it's just, it's not in their hospital. So they don't have the expertise even in an academic institution. And as some of you said also, it's not because you're a sleep expert that you are a sleep expert for achondroplasia. Then other things where in clinical practice, all physicians are not trained aware of specific milestones. So that's really a problem of not being aware. And then very challenging, burdensome for parents to follow positioning and handling. I think that's probably referring to the recommendation we have for preventing thoracolumbar kyphosis. And then here, yes, that was the thing about lymph lamping, so that they do mention it, but they are not encouraged. It's not the right time. So I think many centers do not discuss this when the child is below 5 years of age, and do discuss this later on around puberty. So that leaves us with the last slide with questions to evoke a bit of discussion amongst us. The first question that we have to pose to ourselves is, well, is it important for individuals, for families with achondroplasia, that they know these guidelines, that they know that they exist, that they have read it? So that's the first question. I don't think that the second question would be relevant to say, is it important for healthcare providers to know? Of course, it's important. But that the question is more, how can we disseminate these guidelines, recommendations, so that as many as possible healthcare providers taking care of children with achondroplasia are aware and can follow it. And then that discussion depends a bit on what level you are discussing. Are you discussing at the tertiary level, which means at the academic institutions and the reference centers? Or are you talking about secondary, so the regional hospitals, or primary, the general practitioner? And then the last question that we have to take for consideration is, what are the main challenges faced in aligning with recommendations? And I think I probably made some suggestions, but I'm happy to hear your reactions. Thank you for listening. So it's open for discussion, it's open for questions, I guess.
Yeah, you have a question from Aki?
Aki, yeah.
Yeah, hi, thank you. Thank you, Geert. This was an impressive conclusion. And I think it's the problem, starting with the last question first, is that the evidence behind these recommendations is, I think, very variable. And I think we just need to know more about individual issues in order to really make recommendations that are followed without discussion. And regarding the first question, I think everybody should be on the same level, and it is much easier to discuss with educated parents what to do next on the basis of, I think, common knowledge than to have a more physician-based care. And the experience is that many families with achondroplasia have a lot of knowledge and good instincts.
Okay, thank you, Eki. I see Encarna.
Thank you, Geert, for sharing these results. And I think there are two important points. One is that maybe the knowledge and experience is concentrated in the reference center, and it doesn't go to the primary and secondary level of care. And this is an important problem that we have to solve. The other thing is that it seems that it's also important to give or to get more awareness about the guidelines, and also the translation in different languages for the different healthcare providers in different countries, because it's something that was pointed out, and I think we have to keep in mind also. Thank you very much.
Thank you, Encarna. I believe, but I may be wrong, but I think the international consensus statement paper has been translated. Is that correct?
Yes.
In different languages, eh? Yeah.
Yeah, I confirm.
Yeah. And I fully agree with you, Encarna. I think the challenge that we all have as experts, and most of us are actually acting in the statutory academic reference centers, whatever you want to name it, is really to have it distributed, communicated to the levels of the regional hospitals and the general practitioners. And that's maybe a country-specific problem that we have to tackle. But of course, we can learn from each other how to do that, how that is taken care of within each country. For example, here in Belgium, we do have now a network for rare disorders, and which is linking the university hospitals, but it's not. Well, it's also linked the general practitioners and the regional hospitals, but not. It's not that easy. Of course, we as experts are very keen to be involved, but the general practitioner and an organ specialist and the regional hospital have a lot of things to do. So if they have to make time for all these rare disorders and all these other things, it's not easy. So that's really a problem. I fully agree with you. Florian, Klaus, Sven, we have different reactions. I don't know who was the first.
Florian always, I would say.
Florian?
That's rare for me being first. What I wanted to say is that's definitely country specific. And it's on the one side, the expert centers that are relevant in giving people information, but also the patient organizations. At least for us here, I can say that we as patient organizations have our own information pamphlets, which are quite comprehensive and are very well received by the parents as well as doctors, actually, because it's not one individual parent who goes to the local doctor and tells them, I need 1, 2, 3, but it's an organization in the back with evidence and quotations and like a whole pamphlet saying you need a couple things for your child. So that makes it a lot easier for the families. And of course, with national specific recommendations, that helps.
Thank you, Florian. Klaus?
Yeah, I think it's really necessary to stress what Eki says, that this international recommendation is nice and very valid, but it's only experience related and not evidence based, really. For example, I remember the discussion about when an MRI has to be done. So sometimes people said at 3 months, and then others said 6 months, others said 9 months, and it's more from the experience and not from real data. So I think it's a very good starting point. And I think Florian is right. It's good to have national, but if you have the international expertise together, then we can really have more from different aspects, not only from the developed countries, but also from other countries who don't have all capabilities to diagnose, for example, or to treat. And so I really want to stress that we are only on the first step towards real recommendations.
And Klaus, do you have any ideas of solutions? Indeed,
yeah, you know,
I mean, this is not really evidence-based, but it's clearly not evidence-based. But that's the problem with these rare disorders, and that's it's very
that's
hard.
why I think we need to collect real-world data. And you know, I always go in favor of CRESCNet and similar things, but I think it's really necessary to keep in mind that we only have evidence-based and not so much really evidence which we have to collect in the next 5 years or whatever.
Maybe Klaus, not everyone who is attending this workshop is aware of CRESCNet. Maybe you can briefly explain a bit what it is about.
Okay, thank you. Okay, at the University of Leipzig, I have to mention this because I'm from another university. There is a long history of collaboration in growth disorders, and they have a platform. It's called CRESCNet, and they collect during the visit of the patient data from height, weight, and also historic data and so on. And everybody who is interested in, I think we have to develop a webinar and we'll show. So, but everybody who is interested in to join our project, it's free. It's not for, you don't have to pay money for this because the University of Leipzig already finance the structure. And we already have in Germany, when the buserotide is licensed now, we started a project where we compare the data which are now included about 220 children and adolescents with achondroplasia. And 125 or so are under treatment. So I think it's not enough, but when we get more data, everybody is invited to join our project and send only a message and we will come in contact with.
Okay, thank you, Klaus. And then I see Mohammed and Sven. I don't know who was first, but well, Sven is most on the left side on my screen, so I give Sven the word.
Okay, thank you, Geert. Just want to make 2 comments. The first one is on the first bullet point. I think in many countries, the management and follow-up of individuals with achondroplasia is a kind of shared task between local healthcare providers and expert centers or referral centers. And at least I think for the local or primary or hospitals, I think it is important that they are aware of the recommendations. And sometimes I think the patient is the only link, that because many of these healthcare providers do not see that many patients with achondroplasia. So in my experience, it is often the patient that has to be the link to be aware of it. So yes, I think it's important that they are aware of the guidelines, but I don't think we can expect them to have read it but at least that they are there. And so I think it's important with the implementation and distribution. I think, as Florian said, the patient organizations are essential here, so they can at least have some information and maybe link on their websites, because I think that that's an important way to distribute these recommendations. And also the other comment was on the recommendations is only evidence-based, and I think is at least they are based on the best available evidence at that moment. And the other option would be that everybody is doing what I think is best without any kind of guidelines, and I think that's a much worse scenario. So they are based on the best available evidence and discussed and voted on by 55 experts. So I think that's the best we can do at the moment, and obviously they will need to be revised in a few years, because there will be new evidence, new studies have come, and practice may have changed. But I think at least they represent the best that we know at the current time.
Yeah, thank you, Sven. I fully agree with you. If I can make a comment before giving other people the word, I fully agree with you that the patients can play a role. But I'm right now thinking of, for example, the Netherlands. In the Netherlands, there is a website that is for general practitioners, and that is actually devoted to rare disorders, where you can find for many rare disorders brochures, information sheets about the most important aspects of these rare disorders in terms of management. And so I have been trying to actually do this also here in Belgium, but of course it needs a lot of work and a lot of, and also the national agencies need to support this kind of websites. But that maybe is something also that is something that we could do. And I think also in France, Valerie can maybe comment on that. They also have a very good website. What is it called? Valerie, help me. Oscar, yes.
Yes.
Where you do see the recommendations and how to follow up. And so this is freely accessible for everyone who has a computer. And of course, they have to be aware that the information is there, but I think that's certainly something that maybe many of us have to do. Okay.
I totally agree. We do the same in Norway. The problem is that it's not many people that read Norwegian. Sorry, Sven? So we do exactly the same in our country. We have a website where we have translated it and made it much shorter and much more accessible to patients. But most international people do not read Norwegian, so it's only for the Scandinavian countries there. But we did the same, as you said, to try to make it more accessible.
Yeah, not only for the patients, but mainly also for the healthcare providers outside the. Yeah. Okay, Mohammed.
Yes, many thanks, Geert. What I would like to say that at the national level, we are really customizing the recommendations. And I can give you an example that deserved discussion. It was about foramen magnum stenosis. And we know from the recommendation that asymptomatic patients with achondroplasia can deserve MRI. And this is something that we did not agree, because we need more clinical signs, neurological signs, and other markers. So that's an example, just an example. So this need to have guidelines as soon as possible updated based on the real world life. And then what we are realizing that we need a network, as for many other rare diseases, for follow-up with non-academical centers. And this to avoid families' burden, save cost, and others. So I think that non-academical centers should be deeply involved in together with the patient advocacy group, of course. So this is my comment. I don't have questions.
Thank you. I'm just looking at the agenda, and I'm not sure if we can go on, because I see after this session there's an overcoming barriers to best practice that should be moderated by Encarna. Should we stop here because it's time, or should we go on? I'm not sure what to do, so please advise.
Geert, I think it's going to continue the discussion, and thank you very much we can also collaborate is okay. But I think we have some specific slides with a specific question to address in this discussion.
Okay, please go ahead, Dan. Yes.
Thank you very much, Geert. So I think, yes, it's not working my, okay, thank you very much. So these are the questions that we have planned for consideration here in this part of the workshop. And continuing with this reflection, we can think about the key barriers to align in practice with recommendation. What step can be taken to overcome this? And will close alignment with the recommendation address some of the issues we discussed earlier, alignment between healthcare providers and parents, and outcome of importance, improving the outcome of intervention, or managing clinically challenging complications. So these are some of the points that we can open for discussion now among us. In the meantime, we have some answer from healthcare providers, and we can move on to the next slides and maybe to review them and then to open the discussion. Please, can you move the slide because it's not possible? Okay, thank you very much. So if we review the answer of the healthcare provider to improve their clinical practice, to be more aligned with recommendation for care of achondroplasia, we can see that what have been done. Some of them say attend international conferences and participate in discussion regarding guideline and best practice management. Others says to go through the list regularly prior to our co-visit with orthopedic surgeon, physical therapists, occupational therapists, and rehabilitation nurse. Also, regular training of the interdisciplinary team, to create a special center for achondroplasia management in the hospital, at my hospital, longitudinal closer follow-up study, to improve the coordination between the different caregivers for an appropriate multidisciplinary team approach with specialists who are aware of recommendations, guidelines for achondroplasia patient, looking at a locally adapted guideline for our area, funding services to increase profile and provide standardized reviews and surveillance rather than early responsive proactive care and later reactive care, and continual checking against recommendation to ensure ongoing alignment. Might even do an audit service evaluation. So these are all half of the answer from healthcare provider. And I would like to also to address all these things and maybe to give the opinion about that. And please, next slide. Okay, thank you. So the additional question will be, how do you think changes to practice can be implemented to improve, or what are the potential obstacles to change in practice, and can this be overcome, and how? So I think we have many points to address in this open discussion. We have time enough to hear of you with some minutes from now until 7:07. So now, if you want to give us the opinion, we can again to discuss about all these consideration. I cannot see now the control of the hands. I don't know why.
So Valerie has a question.
So just a comment. It's quite important to disseminate guidelines and recommendations, but it's quite difficult to build a multidisciplinary team and to have expertise in all fields required for the management of achondroplasia. So it might be one potential obstacles to changing practice. Because it's difficult to have an expert in neurosurgery, in sleep disorders, in all the fields that needs to be involved in achondroplasia. So sometimes it's better to be able to address the patient to other centers who have real expertise. So it's quite important to be aware of the limits of our management and the difficulties that we have to face. So guidelines are really important because they can harmonize the management of patients, but it's not always possible to build a multidisciplinary team in every center.
Thank you, Valerie. I think this is a very important question because it's based on one answer to say I'm going to build a multidisciplinary center in my hospital, since that only following the guidelines is possible to do that. And of course, there is a lot of expertise that is needed to follow up properly all the patients. So I think it's a very important point. I cannot see because I think I am on the slide. I cannot see the control, the panel control to see the hands. I don't know the problem. So maybe if someone can help me.
Okay, Sergio.
Yeah, I can. So I think one of the major problems was already presented here in one of the slides, I think, is the financing problem of the centers. So I think all the countries need to, there's also, I think, a lot of political decisions to be made, and it's all for all rare diseases. But in this specific skeletal dysplasias and achondroplasia, at least in my country, and I think several other countries, we have teams that informally work as reference centers. There's no specific, there's no, and even for other diseases that are reference centers, there's no budget specific. So it's just people get the stamp of okay, you're a reference, but there's no actually means that help us to develop. So we develop more like and grow a lot by the effort of extra time and trying to invest on experience, and then the patients come and you gather more experience and more. But I think that's also like the patient associations and everyone there should be, depending on the country, of course. Probably France and other countries are not that as an issue as in here, but we need to pay attention to the people governing that needs not only to recognize centers but also give them more means. And I think these new therapies that we'll discuss after will probably help on that because they are expensive. But other countries, it may be the opposite because they are so expensive that they can help to split already the number. I already heard people that think they know well achondroplasia because they know 1 or 2 patients and they already think this is, well, they are experts or they can already, and it does really take time. And I wanted to bring back the consideration that I think Brigitte mentioned before. We need to also spread a bit more between the specialties because this is more common when I see ENT people or see sleep studies people that only saw 1 or 2 that think that it's more that all other children with achondroplasia will be like that, and it's we really need to. I think the guidelines really help on that to pay attention, to bring attention to what is really important, and start by that. And well, that was a bit my comments, not really questions. But I think one of the main obstacles is financing and having proper funding for the multidisciplinary team.
That's true, because also it is a country-specific thing, and also in Spain we suffer the situation, and we don't have a specific budget for the circulation of patients through the 70 different health services in Spain. And then even being a reference center, there are many problems to cross different communities and different health services sometimes. So we need a specific organization and a specific budget for the circulation of patients through different health health systems in the country or between countries. So I think it's a very good point, Sergio. Again, I cannot see the hand, so I don't know who is next. Maybe if you click on the slide for giving me the control of the panel, I can go out from this situation. I don't know.
Yeah, but I was going to take the slides down, but I think it's Geert next.
Yeah, thank you. I wanted to expand a bit on what Valerie said, and I think this is very important. This is also an issue where we are struggling with in Belgium, and I mean the choice what we should do because right now in Belgium, for example, there is no official recognition of reference centers, right? So we don't have at the national level. There is no decision where the reference centers are. And the question is, should we actually try to have this? And this is really what the patients want, because they want to go to one hospital and want to have their care all concentrated in one hospital. But as Valerie says, it's very hard to have all the expertise within one hospital. It's expertise about making a diagnosis. It's expertise about surgery. So only very, very few centers can claim that they have all in-house. And so the question is then, should we then really aim at making expertise centers and reference centers where patients go always to the same hospital? Or should we rather think of networks where there is a coordination maybe by so-called a reference center, but that the network is providing the care to the patients, where, for example, if he has to have sleep studies, he goes to the expert, which is maybe not in the same hospital as the orthopedic surgeon who is doing the surgery, and maybe not in the same hospital as the neurosurgeon who is doing the compression. So that is really, to me, a difficult question and a difficult kind of thing to solve. So I would love to hear the experience from other countries where you have this concentration of expertise within one reference center, for example, in France, I guess, and not that much the network model.
I can just answer very quickly. We have a network with reference center, with a coordination of reference center, and then we have competence center. So we have coordination in Paris, but we have a network of competence centers, but not all competence centers have a multidisciplinary team. So we are discussing every week to know what if needed, what will be the best for the patient. So we are just discussing together. And if there is no expert in orthopedic surgery, the patient will come to Paris or to another center. So we are just trying to do our best to offer the best to the patient, because we know that it's quite difficult to have expertise in every city from the network for every field.
Yes, Valerie, in Spain, for example, the reference center that we can apply is for orthopedic only. So the reference center is built on the orthopedic expertise. So maybe the center lack of other expertise. And then this is very difficult, of course. And we don't have all the criteria from the different specialties for being considered a reference center. So this is a very important question. How is recognized in every country, and how is organized? I'm going to give next for Sven. Yes.
Yes, thank you. Just a few comments on the obstacles, and I completely agree with both Geert and Valerie that we are dealing with a rare condition or rare conditions, and I think that's some of the key issues that we are in kind of competition with the more frequent and large patients groups. So it is a challenge to establish multidisciplinary teams to get allocated resources, and maybe even more in adults, as most pediatric departments are a kind of have a more tradition for working in a multidisciplinary team. But even though I think it's one of the obstacles is that I think many of those clinics are based on idealists, that some people really are getting into this, but when they leave or retire, things fall apart. So it is a challenge that we need to establish a more permanent structures that is not only based on an idealist or one person, but it actually had to be a more permanent and consistent system. And I think at least that the guidelines and recommendations that both have been provided by the international statement, but also by EAF, at least can be helpful in trying to set the standard, so we can use this when we are discussing with the healthcare leaders and politicians, because we need to need what is the optimal or recommended standard, so we can try to work against it. If we not can fulfill it completely, we can at least have that as a long-term goal, what we want to work to achieve.
Thank you, Sven. I think it's a very important point to make about this consideration. So now, Melita.
So our problem is that we are victims of our own success, and that we are not able for much longer to be able to take the capacity of referrals that are being made to us. So we're trying to build a new model, a much more of a hub and spoke model, because we certainly know we have friends in the field, as it were, who are interested and willing to help treat patients with achondroplasia, but who do not deem themselves to be experts. So with our guidance, are starting to do so. So we're trying to stick to treating and managing the youngest children and the children at transition. But in the middle, we are relying more on our colleagues in other specialist centres, but who would not necessarily deem themselves a specialist in achondroplasia. So yeah, just.
Well, this is a very important point too. Maybe there are some reaction about that. I don't know if everybody would be agreed about that, to only to follow patient in the youngest age, and then the transition, and in the middle to share with other professionals.
So I think it's, yes, I do agree, because we are following a lot of children, and it's impossible to follow all achondroplasia children. So yes, I think it's a very good possibility, but we need to work on it to find the good centers and the good. We have good friends also.
So this could be the new model that Melita is saying to us, and maybe in that place we need to make awareness, to build a real network, to identify the expertise in different centers, and also to go to primary and secondary care level. Thank you. Penny, please.
Thank you very much for the opportunity to be involved. It's been very interesting today. One of the things I want to bring up, and it's a little bit of a change from this, is one of the challenges I think facing us is making sure that research doesn't focus entirely on the clinical trials, and that there continues to be research supporting or giving us more evidence, so that future guidelines are not eminence-based but are evidence-based. And I think we need to really push that research runs in both areas, because I think what's come up from today is that there is still so much that we don't know or that we're not fully aware of. And I think with the introduction of the clinical trials, that's exciting and we're getting lots of good information, but there is still so much more information we need to have that I think we need to be promoting in our centres, trying to ensure that research is looking at both sides of an issue.
Thank you, Penny. I think it's very important what you have said. And Klaus, please.
Yeah, I think one point about that in every center should be all disciplines. I think this is not possible. And so from this, I think we should really have a good collaboration. For example, in our case, we have this collaboration with a distant center who cares for the neurosurgery, and I think this is something which patient has to accept, that you cannot have all the expertise on one place. You have really to have a good collaboration, and maybe telemedicine helps a lot. And I think this is the only way to get first enough experience in one center, and on the other side, a good care for all patients.
Klaus, and do you think that we do have separate criteria for each specialist to be involved in the care, in the long-term care? I mean, so far, mainly every center has to be a general expertise, but we don't have a specific criteria, such a number of, let's say, number of patients followed so far for every discipline. It's it's for the center in general, at least in our country. So you think that the criteria for accreditation has to be for every specialty separately and not in the center itself?
Yeah, I think you need close collaboration over the limits of one hospital. So if, for example, our neurosurgeon is sitting in Mannheim at the university, and we have a teleconference with him, with the diagnosis, then he is part of our multidisciplinary team. It doesn't matter. He is really a professor of our university, or someone at another place. So we have to realize a center shouldn't be only a center on one place.
I fully agree, Klaus, and I also believe that that is the model. I was just wondering, in Germany, are you then forced, for example, the insurances and the health authorities, do they say, well, if you get neurosurgery for this kind of condition, you have to go to that expert, or otherwise you will not be reimbursed? I mean, to make it very strict. So is it all free, or is this, I mean, is this just a decision amongst hospitals, or is this really forced?
It's not. It's not forced, but I think most of my professional career really sent the patient to some other places, and not to say, if I know that whatever at a another university is the best expert, then I send this and the insurance will pay for this. Sometimes I have to make a letter, but mostly it's not a problem.
Okay, thank you, Klaus and Geert, and Mohammed, please.
Yes, thank you very much. The fact at national level, in my center as Children's Hospital and background in skeletal dysplasia, we have the largest MDT. But we are trying to set in collaboration, as Melita said, as hub and spoke, with other non-academic centers. But to my view, this will be very dynamic, also based on the parents' trust and satisfaction. And we have experience with X-linked hypophosphatemic rickets with the treatment with burosumab, where a lot of patients was collaboration with other centers, and again they were back to other centers. So I think this will be very dynamic and unpredictable, but we are trying to set up such collaboration with other centers.
Thank you, Mohammed. And Marco?
Yes, but we have to do a question. What is better for the patients? We are speaking for HR quality of life. What is HR quality of life in this case for patient? What we mean for collaboration? Because the risk is that maybe all the family has to go around the country, now in a center, then in another center. This is what we mean. So I think that we have to do something that we probably, I don't remember the name, is Sergio probably before said. Now the most of us aspects are about the healthcare system organization and are political, because it's not only reference the how is organized the healthcare system, but we need financing. We need the volunteer of political volunteer to do something about that. Otherwise, we can. This is we are make a list of dreams, but then we know that it's impossible to resolve to do it, because we have to collaborate with the political to realize this, what we are going to say, what we say. Otherwise, this is only dreams. And I think that we have to make attention when we say collaboration, what we mean for collaboration with other centers. Because for a patient, of course, the best solution is to have each center with all the specialization, and you don't have to move a long distance, and to find what you need in every center. But of course, we are a rare disease, we are a specific condition, and we have to resolve some structural problem with the politicians.
Thank you, Marco. I think it's it was the first point done by Sergio, and now again you point to the organization and political question, and I think it's very important. Now we need to move to the next presentation, and Iki had before raised the hand, so I don't know if he wants to make some comment about the discussion before we start the presentation.
I just built it in.
Thank you very much. Now the presentation is how might therapeutic option impact clinical management. Thank you very
Well,
much, Ike.
thank you very much for the introduction. And I just follow up on the question of Svein and a comment he made that we need some update on the clinical recommendations in some years. But I would like to contradict, because we are in the process of needing guidelines now and also to need adapt guidelines. And I tried to show this by a practical example. So I hope I can move my slides. Yes. So I don't think I have to remind you that there are a number of comorbidities, but this picture should just represent that these comorbidities in achondroplasia have different impacts. And they don't come at the same time, and they don't have the same acuity and the same urge to come up with the clinical management. I think it's beyond discussion that the most severe impact will be death in infancy by compression of the myelin. So that is something that has, I think, attracted most attention in trying to come up with clinical management plans that address this major complication. There are other very severe complications, and they may have also a very severe impact on the quality of life of children and their families. And while I think there is consensus on what to do in principle, I think the outcome really depends on doing this in the best possible way. And the advent of therapy, pharmacological therapy, has added a variable to all these management plans, and we need to come up, I think, with quick solutions. So just to get the main questions right, to have the right answers in the end, I think vosoritide therapy has its own management plan. So we need to address the issues of safety, the supervision of correct application by the parents, the efficacy of therapy, in order to be on the safe side that everything is correct just regarding the pharmacological outcome of vosoritide. And we need at the same time to monitor for the known complications, and the way we did this on the national and on I think a consensus level. But we need to adapt this fast, because growth changes everything for many aspects of achondroplasia in small children, but also on teenagers and adults. And what I think has not been addressed much lately is that we may have to be very vigilant what happens in children that are outside of the studies or the study data, so far as we have the possibility to treat children earlier than we have data on. And to make this a bit more practical, I would like to discuss a case that I have presented lately already. So achondroplasia may be missed at birth. So the growth failure is the most, I think, frequent presentation that leads to diagnosis at later ages, as in this young girl who was below her centiles in an increasing way. And after diagnosis in the 3rd month of life, there were no real problems in the clinical course, and we've seen her on a 3-month basis. So the German schedule says that you don't need an MRI before the age of a year, in a neurologically normal child. So even though growth failure increased and the normal centiles give you an increasing standard deviation from the median. Again, if you use ACH centiles, everything seems normal. So we had this MRI at the age of 14 months, which seems to present a significant danger. And we did follow up at 3 months, and I think everybody hopefully agrees that this is a significant narrowing that can be classified as ASFM3. So she stayed neurologically completely normal, besides I think minor deviations in her exam. And this gives you, again, the oxological parameters at the start of vosoritide. And this is what we do when we start vosoritide. We need the genetic confirmation of achondroplasia. We do comprehensive oxology in order to monitor what vosoritide does. We look at bone age, but we of course have to assess the major complications that are present under therapy. And this is the image at the start of therapy. So we did another MRI, which didn't show much improvement. And if you use reference values, you see a significant narrowing of the foramen magnum. This is far below what you see on asymptomatic ACH. And this is after 6 months of vosoritide, where we see a good improvement and a good response. What we do in addition is that we monitor cGMP in order to assess therapeutic efficacy. As you know, cGMP is downstream of binding of vosoritide to NPR2, which is the natural receptor. And you can see that urinary cGMP concentrations follow an increase of growth velocity. So we are pretty happy with monitoring therapy itself, but we are not very happy with what we see on MRI. Just looking at the data, you don't really see an increase at the foramen magnum. And although she stays neurologically normal, also SSCPs don't show pathological deviation. We decided that we need more follow-up. So as we have a schedule for the first year, how to monitor vosoritide therapy, we think that we need further examinations, including MRI, in those children where we have significant narrowing of the cervicomedullary junction. So that changed the schedule even in the first years. So we really think that children with significant foramen magnum stenosis at the initiation of therapy need further monitoring and close monitoring. We also, and I don't show data on that because of time constraint, do regular screening for lower spinal stenosis and monitor that under therapy as well. And we do foresee, and we have some data on that as well, that the increase in growth velocity really changes the management of hemiepiphysiodesis. And I suspect that all the other comorbidities need to be monitored on a different schedule. So other countries are far more advanced. So this is the French schedule that is stole from Geneviève Beaujard from her presentation. So they plan ahead for 2 years. And they also include DEXA and I think comprehensive radiology. But I think as we treat those children and also smaller children than the French, we need to come up with revised schedule soon. So I think the main message of what we see in smaller children at the moment is that we really have to think and to adapt fast. And we did not really see a non-responder, responder in almost 60 patients or more than 60 patients now that we treated for at the 6-month control. But I'm pretty sure that we will see different response in terms of therapeutic efficacy, and need to think what we do then. We did change the schedule that we have, and we try to come up with an adapted schedule soon, so we can really share what we do or what we found out so far. And I think we really need to think also on a consensus level what we do in terms of complications that we don't expect at the moment. And that's the take home. Thank you very much.
Thank you very much. Very, very, very important question. I think this is an important time to think about that, because we don't know the long-term natural history and the treatment, and it's an important question for all of us. We have Eki, we have a Zoom pool, and we have we don't have time enough for questions.
No time.
So maybe even we have we are out of the time. I think it's an important topic, so important that we have to address this question more deeply, and then we have to go on. And if you have any question, any of people who are participating in the workshop, please send this question to Eki, and I think you will be happy to answer to, I think. Eki?
Yes.
Thank you very much. Thank you very much. And of course, we can go on. Even if you want to close with some consideration, Eki, please go on.
I think we are really in progress, and I think the points that have been stressed already have to be, for me, the most important points have to be that we really need to collect as much as we can in terms of data, but also in terms of how the families really cope with a change, and what they have to do in order to treat their children. It's the therapeutic burden is on the families, especially for smaller children, and I think this needs to be addressed, and it needs also to be addressed to manage what you really expect from therapy. And we have no good answer for that at the moment as well.
Exactly, we need data and collaboration, and I agree totally with you. Thank you very much. Now we are going to close this session with this summary, and we have seen that there are differences in opinion between healthcare providers and parents on key outcomes of importance, and also the complication of achondroplasia that cause the greatest challenges. There are guidelines and recommendations in existence to support best practice. Some difficulties exist in aligning with recommendation in practice. We have discussed potential option to overcoming barrier to best practice. We now have a therapeutic option available for achondroplasia. There are no recommendations currently available for how to fit vosoritide into treatment planning. finally, as the field progresses and treatments become available, these conversations are more important than ever to ensure we can improve outcomes for our patients. And I think this has been a very interesting workshop. I would like to thank you, all of you, the speakers and people who are attending the workshop. Thank you very much for your attention.